Dopamine, right? Dopamine's right. Right. Oh, and dopamine. And dopamine. Well, let me just explain first. The basal ganglia is actually a couple structures in the brain. It's not just Does anybody know more specifically what Parkinson's is, Natalie? What's Parkinson's? What nuclei are being specifically affected? What nuclei in Parkinson's? Or Ashley, either one of you. Right. The substantia nigra, which the basal ganglia is not just one section of nuclei, it's a whole slew of them. Basically, the basal ganglia is a couple different structures, actually. I know people think a lot of simplification. They think basal ganglia and Parkinson's. Well, basal ganglia that's really not accurate. Basically, you have your thalami here, because you have two thalami, right? And you have something called the lentiform nucleus. So lentiform nucleus. Then you have what? I just sent it. Some of your Zoom classmates are not getting in. I don't know why.
Some of them, they have problems with the microphone.
Really?
I'm sorry, with the audio.
But you guys can all, you obviously can hear me. Okay. Hopefully that works. Oh. Oh, wow. Yeah. So basically, are you familiar with Zoom? I need to know. I'm teaching from it, but I'm not that familiar with it. I'm going to actually try to figure out more over this next weekend, but I'm Zooming to students from a different campus, so they're basically at home.
Oh, okay.
And it's a program that allows them to watch what's going on here. But
So it's kind of like, not really like Skype.
it's, I guess you could say it's like a laptop. I guess you could say it's like that.
Oh, you might have to enable it on your
Oh, I don't know.
yeah. Mirror.
How do you know how to do that? This is a new MacBook. I
I think either F3 or F4. It's probably one of those, I think.
Shift?
I'm not 100% sure. I know how to do it through the menus, but I know there's a shortcut. I don't want to say I'm 100% familiar with the Mac, but
I'm
yeah, just preferences.
I'm technologically incompetent.
Displays.
It's the truth.
And then
he might need to decrease the resolution also.
Okay.
oh, I see what you're saying. Okay.
Built-in retina display, wouldn't that be? I know there's a guy in HBO who seems like he's like a super tech guy. I wish he was here.
Yeah, click on the built-in retina display on. Not coming up. There's usually a mirror option.
Oh. Arrangement maybe. Mirror displays.
Okay.
Show main options. No. You may need a Mac display adapter interface with
yeah, I think for the older Macs, they don't have the HDMI, allowing them to those front end. Let me try that.
I'm trying to connect it so I can see you guys also on the big screens, then the audio will be better also. So.
Go back to the system preferences. Display.
Okay.
Click on scales. See if we can change the resolution. I'm not seeing because normally there's an option, maybe the newer one.
Space. Yeah, this is the 2017 Mac.
Yeah.
Without the ID thing.
I know.
Oh wow. That's not good.
On the older ones, you can just change the resolution, but here I'm not seeing it.
Projector.
Try it. That's for color.
No.
Go to display again.
Gather windows. I don't know what the hell that means.
I think it's Alright, give me a second, I'm gonna make a call, see if I can figure this out again.
Extension. Does anyone from HBO know how to do anything technologically advanced? I'm incompetent. I'm trying to think. Because that would be good if we could get all of this working. That would be good. Wish I would come here. No. General business. Yeah, they are. Oh, wait, size. Okay, I'm just gonna start till he gets back. Well, hopefully he figures out how to do this. That would be awesome. Okay, let's focus on basal ganglia. It's the lentiform nucleus, which is this cheese-shaped structure, which consists of the putamen and the globus pallidus. Okay, I'm not going to go into details about. There's two portions to that. Then you also have what's called a caudate, which I like to think of as a head and a tail as well. That's what it is. That's also part of the basal ganglia. Then beneath that you have, so this is your thalamus. Beneath that you have the subthalamus, which is also part of that. And then on top of the midbrain, you have two other nuclei, and that's your substantia nigra. So this is the subthalamus, substantia nigra, which is also two parts. So those all together constitute the basal ganglia. So you have the caudate, head and tail. You have the lentiform, which is the two different portions I said down there. You have the subthalamus below the thalamus. Then you have the substantia nigra. That together is the basal ganglia. Hey, good buddy. Help me. I'm trying to hopefully get this on the screen. So, because the program Zoom I'm using, but there are students remotely watching me from this program. I'm trying to connect it to the main system, so hopefully I can see them. And some audio can be studying also. I don't know if that's even possible. Mm.
There we go. Is that way?
Yeah. Just
And again, why is it once?
it was just went away.
It just went away. That was maybe.
No, hold on. Let me
Not the,
see
yeah, this is a brand new cable I just grabbed.
Oh, sorry.
Maybe not.
maybe something was happening here.
Yeah.
I'm glad you saw this came out.
Yeah, it like popped up. Yeah, like
Which is what should happen.
Right.
shouldn't go away.
This is why you guys are ordering stuff.
Yeah, let's just change it like the Zoom.
Yeah, some might have kids.
Kind of how I work at home too. I was like, hey,
I have a 9-year-old actually that is the biggest engineer. Where did it pop on?
Let me just mute this for now so we're not getting that feedback. Where's your volume? What it's doing is doing the retina display. If the thing is set too high.
Oh, I put it right in display. There was another one pressed on, whatever that is.
Right, which is the system here.
Oh, I'm sorry.
No, that's fine. Let's mute this for now.
comes up.
Restaurant, well, then it switches. I think it's switching.
Yeah, I know. It looks like.
Scale it.
Oh, I see. Okay. Yeah, that's it.
Problem is, it doesn't give me another resolution to play with.
Yeah.
Hello? Hello? Yeah,
That's
at
what,
all? Just a moment ago?
a 13. Oh, 13.56.
Yeah.
You probably hit the button.
I want to scale it down further, but I can't.
Yeah, I'll react to it once. Yep. When you guys hit the microphone thing,
Definitely.
yeah. Once you, now I can't. I'm not on the computer. I'm just trying to get so the classroom can actually basically shoot the feed around all the videos and microphones around the room. Then it would be
See how it gave me that scale, the resolution scale?
Yeah.
because it's full of video screen.
So
Because we
that'll
plugged
do.
it in initially.
Zoom in and out with that. Yeah.
Just a minute ago.
Try resetting it now.
Well, I'm not coming to computer now.
You know,
Now I can hear it.
crazy.
You just started on class.
It's working now. Yeah. Muted. Okay, it's fine. I'll fix it when I get back.
Yeah, I'm gonna. And this software you're using is only on your laptop?
Yeah.
What's it called?
It's called Zoom. Well, no, I can guess you could. No.
It's web-based?
It's web-based.
All right, let's do this then because I don't want to take too much of your class time.
Fine, I get it.
Go ahead and log in here. And then what we can possibly do in the future, we
Connect from here.
yeah, just log in here. When is your next scheduled class?
Next week, Thursday.
All right, is it possible for you to, what's your availability? You should be good. This is the last class. Can you schedule me?
139?
Yeah.
Yeah,
Then,
that's fine.
what's it for him? R25. Looking at
This room is
Okay. Is it possible you can come in like about, I don't know, between an hour and half an hour before class?
Yeah, absolutely.
All right, but then I can,
I didn't come in this time because the room door wasn't open, but I can come out before. That's
yeah,
fine.
we'll make.
I'll make sure I schedule myself to come out before. Yeah.
All right, what we're gonna do is, because typically it's half an hour before the class, but because of this, so we need to look into this further.
I got it.
we'll open up before, more likely I'll be the one meeting you.
Okay.
And we'll be looking
So I'll
into
come
this.
around before next week Thursday. I'll be here by 4.
So for now though, let's get you up and running and then we look into this. There's definitely a scaling issue. It's pushing a higher resolution of what it can take, and then it's
Just go to Zoom.
that handsome guy over there. The only problem though, they won't be able to see it. You need a webcam.
Yeah, you need a webcam. Would these cameras work though?
It's a regular class, right?
No, this is a scheduled VC, but there's no hardware.
Yeah, there's no one.
Wow.
This is a VC though.
I guess I don't know what my
I'm trying to think on the fly how to get him up.
Yeah.
That's it.
You'll definitely be able to see and hear them, but they won't be able to. It's a scaling issue. Worst case you can also do is, or laptop. I'll try to link to it. Or a laptop is better than a calendar.
We have any more?
Oh, I see what you're saying. Put it
Oh,
here.
that's the PC.
You want to do that?
Are they in your office?
Let me grab it.
Alright. The way the room works,
Right.
you can't really access those cameras. Those cameras are specifically for the VC.
I see.
So what we're gonna do is gonna grab a USB camera and we're gonna plug it into the computer.
Okay.
So at least we can get on the projectors, we can get
Right.
sound, and they can hear you as well.
Right.
Because these mics and the cameras are set up specifically for the VC, so it's not computer based.
For this, I got it.
Yeah, yeah. Because what you wanted to do is you want to use that camera through your computer, correct?
Basically, and with the sound volume.
Yeah, that won't
that's
work
not
like
gonna work.
that. Yeah.
Davey, what exactly is happening now?
The professor was trying to use software similar to Skype to meet up with students that were at home, and he wanted to use the in-house microphone and video cameras to speak with them using his laptop. As I told him, that's not currently possible. So what's happening right now is we're just going to hook him up with a USB webcam to connect to the PC because his MacBook was not connecting with our projectors here. It was having a scaling issue.
I got you. Thank you for informing me.
You're welcome.
Oh, maybe 2 more.
What was it asking?
Another meeting. I tried a
Oh,
meeting
because
going on
it's
here.
probably still
Yeah.
connected to the, yeah, I see, I think it just closed out, yeah.
Yeah, 'cause there's no camera, right? I see what you're saying. Huh?
Yeah, there's no camera,
So,
so we're gonna try to get you on. So let's get this going and not take up too much time.
just check the cameras again.
You want to hide the projector?
I'm sorry?
You want to hide these so the students can't see, or you don't?
I don't care. Yeah, it doesn't matter. Thank you, though, for asking. Okay, hopefully that allows him to join now.
Yeah, I'm gonna connect this, so refresh it in a second.
Oh, yes. Awesome.
I don't know what would be the best here.
Okay. That should be a lot better.
Yeah. If anything, you might be able to kind of, your this moves around a little bit, but not too much, so.
I think this should be. You can see the whiteboard is all that matters.
Yeah.
Can you guys see the? Are you guys able to hear me? Unmute.
Yeah, it should be on. If you hear others, just click join audience.
Yeah, join on. Can you guys hear me? No, unmute. There we go. Can you guys hear me?
Yes, can you hear us?
Yes, perfect. Okay. Oh, that's so much better. Okay, I sent a new link for the please use it's on Canvas is a new link. Okay, this should work a lot better. Okay, perfect. Yes, can you hear me? That's not up to me, unfortunately. So that's up to administration. I will ask the assistant dean because I did request it was recorded. I know the previous one was. Hopefully this one is also. I don't know. I'm not sure, but I'll request that also after this course or after this class. Right, I know, but at this point I don't even want to waste more time talking about it. At this point Zoom is working, so let's just get the class, please. I am a little frustrated, as you can tell. Yes. All right. Bye.
Everything's good?
Yes, that's good. That's much better. Thank
All
you.
right, you're welcome. Anything else, let me know.
Okay, no problem. I appreciate
Turn
it.
on these lights to glare, or is this okay?
No, it's fine. It's fine with me. Okay. How is the screen for you guys now? The whiteboard. So I can adjust the camera.
Kind of crooked. That's good.
Yeah, that's good. Okay, perfect. All right. Okay, so we're talking about the basal ganglia. So basically, these structures constitute the basal ganglia. Parkinson's is a disease that affects primarily the substantia nigra. It affects the dopamine-producing receptors in this portion. The substantia nigra, again, is right on top of the midbrain. It's an autoimmune disease that causes destruction of these nuclei. How movement is relayed, believe it or not, first there's a thought process. It gets sent to the basal ganglia. The basal ganglia, and this happens obviously instantaneously almost, regulates how you want to process movement, sends another signal back to the premotor cortex of the brain, which then sends a signal down to your corticospinal tract, which we discussed last week. So basically, it coordinates movement. That's why it's so important. It coordinates all of your muscular movement. So basically, let's just say the circle of your basal ganglia, that's your premotor cortex. How movement is actually coordinated, how actual movement is coordinated. The basal ganglia cortex sends a signal to the basal ganglia about what movement it wants to do. The basal ganglia then processes that signal, that movement, coordinates it, sends the signal back to the cortex, and then the premotor cortex and the motor cortex then send the signal down to your muscles. So there's a signal first, the thought of movement, basal ganglia processes that, coordinates it, sends it back to the brain, and the brain shoots it out to the body for purposeful movement. So when you have any kind of issue that involves one of the neurons of the basal ganglia, like Huntington's chorea, Tourette's, believe it or not, involves one of the constituents, the subthalamic nuclei. That's what's affecting Tourette's, and obviously Parkinson's is the substantia nigra. So every kind of movement disorder, it's from one of the nuclei in the substantia nigra that's affected. So basically, with Parkinson's, we're talking about dopamine production.
Becker,
Yes.
we can't see the board.
Let me redraw it. No. I won't. Again, basal ganglia, motor cortex, signal, but I want to move my arm. Shoots a signal on the basal ganglia coordinates that movement, sends it back to the brain, and then the brain does the purposeful movement down the corticospinal tract. So basal ganglia, brain. And we're talking about obviously the premotor and motor cortex. So basically all those nuclei in the basal ganglia, they coordinate your movement. That's what they do. Without any kind of dysfunction, those nuclei causes dystonic movement, dyskinesia, okay? So some of the things I mentioned earlier, Huntington's chorea, Tourette's, Parkinson's, are all problems from the basal ganglia. Okay. So now we know Parkinson's affects the Parkinson's. Substantia nigra, it's the pars compacta portion. And we're talking about dopamine. So what happens when we have the loss of dopamine? What are some of the symptoms? Tremors. What kind of tremors? Resting tremor. That's important. So you have a resting tremor. That's one cardinal symptom. What's another one?
Rigidity.
Rigidity, right. Does everyone actually know what cogwheel rigidity is? Emily, come up here. Hurry, hurry. Okay, so basically I'm gonna control you on. When we cogwheel rigidity, when you're actually pulling it's gonna be like this. And then once you get to a certain point, it'll release. But it's gonna be like, it's like cogs, like, well, sorry. That's what cogwheel rigidity is. So you'll basically, it's really like a cog. But once you get to about this point, then it'll just release. That's cogwheel, you guys, so when you do it, you'll feel that resistance, and it'll be like literally, and it'll just release. That's cogwheel rigidity. So I know that big term, what the hell does that mean? That's what it means. So, and especially cogwheel rigidity, that's what you see. And what else? What's a big one? Bradykinesia, right.
Low
Well, what is mass species, is not just a byproduct of all of this? Yeah, it is. So, is that a symptom or a sign? Kind of wrote it already, didn't I? Ignore that cap. So expressionless, right? Another big thing which is not really discussed much in, does everyone have those three?
shuffle gait.
Shuffling gait, fenestrating gait, right. It's fenestrating gait, which is shuffling gait. Right. And that's from the lack of coordination. That's the lack of coordination between the muscle. The two neurotransmitters that affect or balance muscular movement are acetylcholine and dopamine. Okay. Does everyone have that? Yes. Okay. But one big, huge portion of Parkinson's that no one discusses, which is really honestly one of the biggest issues, is the autonomic dysfunction. That's truly probably one of the biggest issues of Parkinson's. It affects the autonomic nervous system. You have increased sweating. What's the medical term for that? No. Hyperhidrosis. What else? What's another? Oh, you have, and this is probably the biggest issue. I have postural hypotension, orthostatic, right? So what are we going to see happen with the heart rate? It's going to go up, right? Postural hypotension. You know it's on a vasovagal form because the heart rate's going to go up. And it's going to be almost immediate upon standing. It's going to be very rapid upon standing. There's not going to be much of a delay in the drop in blood pressure. What else? Constipation. Urine retention. These are all, honestly, these are the biggest problems with Parkinson's. The patients, these are the most of the complaints we've had. And sweating is a huge one, believe it or not. I have patients, they just can't take it. They literally, they just can't take it. And if you see them in the morning, like I have the benefit of sometimes going to the ALFs and they're in their bed. The bed is, it's like it's drenched. It's drenched. Anyways, so, but this is the biggest one, and this needs to be treated. And also you have depression, some of the other things that go along with Parkinson's. So how do we treat Parkinson's if it's a dopamine problem? What drug, guys? Come on.
Carbidopa, levodopa.
All right, cinnamon, right? I don't usually use brand name, but we're going to treat with cinnamon. That's unfortunately really the only significant treatment for Parkinson's still to this day.
About deep brain stimulation.
Deep brain stimulation is, but, and what does deep brain stimulation treat? What does it treat? No.
The symptom, just reduce
what?
the symptom.
It treats only one symptom, but it really does a good job.
The tremors?
Tremors. And basically, in order to get this covered by insurance now, you have to prove that the medication is ineffective, that the patient is basically, at which end? I mean, it's the process now to get a deep brain stimulator is very difficult. It's two devices. You have a generator. Which is basically the battery. And you have the leads that are put in the brain. So it's like a pacemaker. The generator is put in the chest, and you can adjust this with they give you a little control. You can adjust the settings to control the. It's actually an excellent tool because you can pretty much get complete arrest of all tremors if the patient's good at adjusting. And this is something where the patient really is taught to adjust themselves, and you can pretty much get rid of the tremors. I've seen patients without any tremors with a deep brain stimulator. So that's a surgical. I was going to go to that later, but yes, okay, deep brain stimulator.
Would the increase in acetylcholine prevent their ability to compensate during like shock?
In Parkinson's, it's dopamine we're going to give.
No, I was saying, like if their ability to compensate during like shock or something.
Oh, no, actually it wouldn't affect that. Their autonomic dysfunction probably would be a problem, though. Would probably definitely be an issue. That's a good question. I'll get back to you on that one. That's a really good question. I've never even thought of that. It's a good question. I'll look into that and I'll give you an answer. Okay, so we have. He asked if it affects your ability to what? Oh, that's okay. I'm chat. That's a good question. You guys heard the question he asked? If some of the issues related to Parkinson's would have a problem with compensating for shock, like how would it affect somebody in Parkinson's who went to shock? Good question. I'm not sure. Okay, what's the next? We went to drugs. So we did cinnamon, which is the big one, which is the carbidopa levodopa. What's the problem with cinnamon? But why? Why doesn't it work? More specific, why? 9% is destroyed crossing the blood-brain barrier. So you really get almost no effect from it. If you guys ever seen that movie Awakenings, really good movie. Anyways, it's a good movie. Awakenings. Neuro, Robin Williams. But anyway, it's some relation to this issue. But anyhow, cinnamon, you lose most of it in the blood-brain barrier. So you have a couple solutions to that. We have COMT inhibitors, which prevents an enzyme from degrading dopamine. They help. Entacapone. That helps to decrease the degradation of dopamine. So it potentiates the actual dopamine, basically. What's the combination drug? Jesus, what was it called again? I can't remember. There's a combination drug that has the levodopa, carbidopa, and the COMT inhibitor. Then you have dopamine agonists, which were really abused initially because we thought it was a great drug. So your dopamine agonist. What? One of those. That's a big one, right? What's another one? Right. Ropinirole or pramipexole, they're dopamine agonists. And they actually are really effective with Parkinson's. The only problem with these is side effects are really bad. The rate of hallucinations and psychosis with long-term use is horrible. So we've really limited the use of these. A lot of neurologists won't even use them anymore. What's another drug? Amantadine, right? Amantadine, we're not sure how it potentiates dopamine, but it does. And there's some neurologists who believe that when it comes to some dysphagia associated with Parkinson's, amantadine is a good drug. You know, whatever, I'm not going to argue that, but amantadine can be used. You really see it used anymore because it's really not that efficacious. And it's usually dosed twice daily. Not that it really matters, but so it potentiates dopamine also. What's another drug? MAOB inhibitors, which also reduce the amount of dopamine being broken down. So MAOB inhibitors. Selagine, refagalidine, those are the MAOB inhibitors. They're more on the expensive side, and they can be used again. But really, your main treatment when somebody has had Parkinson's for 20 years, you don't see these drugs anymore. You really see cinnamon, and that's what you see. You know, quite frankly. The problem is the more cinnamon you use, it's a case of diminishing returns. So Parkinson's is one of those diseases which eventually you die from. And what do you guys think is the number one cause of death from Parkinson's? What? Respirations, yes. The dysphagia. Neuromuscular, right? Think about something you really need to fine-tune to do properly, swallowing, right? Because you have, what, 3 phases of swallowing, right? If I can remember clearly. You have an oral, a pharyngeal, and a esophageal. The second half of this phase, and all of this phase is autonomic. We don't control it. You don't have to write this down. I'm just write down. Basically, this muscular coordination, you end up not being able to swallow. And it happens with liquids. Liquids is the big issue. Why we would think liquids before solids? It's a liquid, right? If anything with any kind of neuromuscular coordination, the liquid's always going to be the problem first. Because you need to really coordinate that swallowing to get a liquid down. It's much more difficult than a solid. So you have a problem with any neuromuscular issue related to swallowing, stroke, anything. Neuromuscular. So if a patient comes to you with and you do a swallow study and they can still swallow all the different consistencies of solids fine and they have a problem with liquids, it's going to be a neuromuscular etiology, 100%. So you can pretty much rule out stricture, right? Web, all of those things which we call a mechanical obstruction. Neuromuscular. CVA, Parkinson's, MS. Okay. So that's it. So Parkinson's, the takeaway, autoimmune disease, destruction of the substantia nigra, specifically the dopaminergic neurons that produce dopamine, obviously. The best oral treatment we have is still cinnamon. There's actually even the surgical treatment, deep brain stimulation, is excellent for tremors, but it doesn't fix any other issues with Parkinson's. There's also an implant now you put through the stomach that actually it's a liquid form of cinnamon, which is basically pumped to something, and it helps to reduce some of the on and off phenomenon you see with Parkinson's. What happens with Parkinson's is one of the biggest things that I've ever heard of, the on and off phenomenon. Are you familiar with that? On and off phenomenon. What? That's actually, if you think about it, what is the on and off phenomenon? Right, because when the cinnamon wears off, you see people frozen, literally frozen. They can't take another step. You give them cinnamon, they start walking in about 15 minutes. On and off phenomenon. That's why it's called that. Literally, turn the person on and off, literally. Falls are huge, dysphagia, swallowing, depression, use your SRIs for depression. That's really about it for Parkinson's. Let's do MS next. MS, multiple sclerosis. That affects it allegedly just affects the neurons of the central nervous system. But you do have some, so it's considered probably an upper motor neuron disease, upper motor, but it's also sensory. So it's sensory and motor. Let's just take it like that. So it's, what's MS? Am I familiar with MS? Okay, well, MS is, it's also autoimmune. It's demyelination. And motor axons. So it's autoimmune demyelination of sensory and motor neurons, of axons, pardon me. Most of the lesions you see in the central nervous system, in the brain, sometimes on MRI you'll see lesions in the spinal cord too. But one of the hallmarks of MS, if you look at MRI of the brain, which is gold standard for diagnosis, is an MRI. That is a must. Lumbar puncture is not even really necessary. You do see done sometimes, but it's really not 100% necessary. Because you can actually have a normal lumbar puncture and still have MS. But and what the MRI will show is, this is your brain. Can you guys see that? Are you familiar with the lateral ventricles of the brain? What kind of cross section of the brain is that? Horizontal, right? Horizontal cross section. And you'll see, and they try to do T2 weighted because that is the best, especially for new lesions. T2 weighted MRI, you'll see little glowing spots, and they almost always, 9% of the times, they coalesce around the ventricle. So you'll see, most of this will be dark, obviously, and you'll see little, like, spots. And they tend to coalesce around the lateral ventricles. 9% of the first lesions are around the lateral ventricle somewhere. And a T2 weighted MRI, you'll see these nice bright up spots. Once, let's say 6 months from now, you're trying to assess the damage, and you'll do a T1. And these will, depending on how much remyelination occurs, you'll have little vacuoles, meaning like almost empty space, versus some remuneration of the tissue that was lost, of the axons that were lost. But T2 weighted MRI, and in 9% of cases, you'll see, again, the bright lesions around the ventricles of the brain, because they occur around the corpus callosum. You'll see an MRI like that. You also see that's your corpus callosum. You guys familiar with that? The connection between the two hemispheres. So it's a mid-sagittal view, and you'll see the lesions around here. Okay? Sagittal view around the corpus callosum and ventricles, and horizontal view. So sometimes in MRI, when it's being dictated, you'll see it referred to, you'll see some of the reference to that. on MRI, and that's diagnostic. Once you see that, that's diagnostic for MS. And the new guidelines say you start treatment immediately. Does everyone kind of get so far the base of MS? Autoimmune disease, demyelination of the sensory motor fibers. So you get sensory and motor involvement. So you can get weakness, which is one of the first symptoms you see in MS. You get paresthesias, strange feelings. You don't not loss of feeling initially, but the first exacerbation, you might get tingling or burning, just like isolate the one area in your thigh. Some very obscure, weird symptom. You're like, what the heck is that? One of the best presentations is about 20% of people present with something called optic neuritis. That's when it affects, obviously, the optic nerve. 20% present with optic neuritis. And what you'll get is a scotoma, which is essential depression of vision, and diplopia. And a lot of people also simultaneously have a paresthesia somewhere in their body. You get those two things, optic neuritis and somebody coming with double vision, and they'll say, oh, and I still had this strange feeling in my left arm or right leg or whatever, tingling, burning. You better think about MS immediately. That's pretty much just a guarantee it's going to be MS.
How would you be able to differentiate that? A lot of people call it stroke will say that there's a blur, numb on one side of the body. Is it bilateral, or is it just
MRI, it's acute. In the acute phases, how would you do? What's the stroke going to manifest as when you do an MRI?
oh, later on?
Right, you do the CT first. No, but if you do an MRI within 3 hours of stroke, you'll see the stroke. You'll see the stroke. Absolutely, you'll see the stroke. It's completely different looking. You'll know. One area you have ischemia, and you have literally with a stroke, you'll have an area that's dark in the middle, then you have areas, rings around it of more of what's called the ischemic zone. Right, the penumbra. Right, ischemic zone or penumbra. You'll know. That's why you do an MRI. Because that has to be, a stroke has to be your differential. Absolutely, 100%. Because if it's a brainstem stroke, it actually could cause all this, right?
Someone called in the other day who had an unknown history of MS. Like, mom didn't know for sure. He was an adult.
Right.
Guy. But he's like, yeah, I kind of managed it, but he was totally toxic, totally failed fast. We sent him over to stroke alert. It was negative for stroke alert, and it ended up being that. But it was.
They sent him up for a stroke alert? Okay.
Yeah, because they weren't sure if they didn't know how accurate the history was. So they're like,
So prior to that, did they start him on high dose steroids? Prior to sending him? Okay, well that's good. I have no problem with that, but yes.
The MS is not progressive. It's not like
It is progressive. Yeah, it is progressive, and that's another differentiating factor. But for first-time presentation, it could be problematic.
Does it most of the time, like when you flare up, does it only last 24 hours, or is it something
Not
that?
necessarily. No, there's no rhyme or reason to it. It can be 2 weeks, 3 weeks the flare can last. Usually shorter. Usually it is shorter, but there's no absolute natural progression per se. And there's some people who have one incident and never have it again. And that's why it's questionable about starting treatment immediately, because there are people who have one isolated incident and never have it again. Never. So in young kids, it's a little bit, I'm talking about adults now. Young kids, there's a lot more in terms of if you initiate treatment or not. You wait usually for a second attack, but an adult, you start treatment. So I want to make sure I cover everything. So let's talk about treatment of MS. For acute exacerbations, what are we going to use?
IV steroids.
IV steroids, absolutely. And if those aren't effective, what are we going to do? Right. Plasmapheresis. In most cases, steroids will work. For maintenance, what's one of the first choices? I don't care about, you guys know the names? I can't remember how to spell it, whatever. Crofelemer, beta 1 and beta 1A and 1B, interferon. That's your mainstay treatment still. There's actually new drugs now being reviewed by the FDA for release. And the reason these drugs are the best tolerated actually, and they're the most efficacious. Basically about slowing progression. Because what happens with MS is slowing progression. Over time, if the same axon gets demyelinated, what's going to happen? It's going to cause what's called gliosis, which is just the axon is replaced by, slowing progression. So you basically have something called gliosis, which is basically just scar tissue replacing the myelin. And actually, the nerve gets destroyed too. So you have an acute demyelinating syndrome. The axon gets destroyed. You have 2 or 3 episodes. Gets replaced with scar tissue. Is that working anymore? Is that functioning? Absolutely not. It's not working. Tell me. Okay. So that's that. And so you have some of the oral treatments too. People who do not want to get weekly or bi-monthly injections can go with oral treatments. I can't see why you would. But basically, the treatment is disease-modifying therapy. That's what it's known as. And they're all immunomodulators. You have oral treatments too. I have no idea, so I'm not going to go into details. But the takeaway from MS is that it affects sensory and motor. That's what I want you guys. Sensory and motor. One of the most common presentations is 20% plus actually is optic neuritis. And if it presents with a paresthesia, MS has to be in your differential. If it's a first-time presentation, there's multiple other things you have to think about too, right? Supranuclear palsy, there's other things, CVA, which are much less, MS is way more common though. So CVA and MS would be your 2 big ones. And really, the nice thing about it, the MRI is really the way to get your answer. Questions?
Would you say that MS in comparison to ALS, that ALS is more symmetrical than MS?
In general, it is. Yeah, it's funny because MS is really asymmetrical. Jesus, yeah, it jumps from body part to body part. ALS is just so much worse. In general, I think it is more symmetrical. ALS doesn't necessarily affect the bilateral cortical spinal tract that feeds off, just like both arms, but it tends to be that way actually in general. But it's not in the literature. You won't see that written. But the cases I've seen, a lot of them are symmetrical. I wouldn't say but there's a lot of it's not exactly symmetrical, but it's far more symmetrical than MS. MS can be all over the place. So to answer your question, yes.
Part of my differential for that was that, ALS has an inline effect of
I can't hear you. You're asking me a question?
Oh, that's part of my differential.
Okay, so, and let's go to ALS since you brought that up. Okay, ALS.
Dr. Eker,
Yes. I lost you. Oh, the feed's on? The feed's on.
there's 5 minutes left.
Okay, I'll have to log back in, log back out, I think. Yeah, I can't upgrade a pro here. Okay. ALS. And we'll take a break in that 5 minutes, actually. It's only be a 5-minute break. ALS is basically, what's it commonly known as? Lou Gehrig's. Right. ALS, and this is a big difference. It affects only the motor neuron. So it's motor only, right? Upper and lower motor neurons. Does anyone understand the difference between upper and lower motor neuron disease? Upper motor, we're talking about the neurons in the brain only. Once it gets to the spinal, once a motor neuron gets to a motor axon gets to the That's your brain. It's your spinal cord. An upper motor neuron is here. And what track are we talking about? Or the cortical bulbar, but let's just keep cortical spinal. You have upper motor neurons in the brain. The axon goes down. Your medulla, it's going to decussate, right? It decussates, and it attaches to the anterior portion. Oh, good lord, that's a horrible picture. The first place it's going to synapse with is the neuron in the anterior horn. Okay, always. Cortical spinal, upper motor neuron. The moment it synapses with that neuron, lower motor neuron. Okay? That's what a lower motor neuron is. That's what an upper motor neuron is. All right? You guys get it? Okay. Because the symptoms are going to differ dramatically based on whether the upper motor or lower motor neurons. And if you think about like sensibly, let's say you have, let's use your deep tendon reflexes for an example. So you have your DTRs. If it's a lower motor neuron, so if the motor neuron here that's supplying that, you think it's going to be, well, how do you think it's going to be? It's going to be lost. What is it going to be? It's going to be abnormal or
Hyperactive.
for lower motor neuron. It's lost. The DTRs are lost. Lower motor neuron, you have either severe reduction in DTR or a complete loss of it with lower motor neuron because it's so low down the chain. If it's an upper motor neuron, you still have some activity because you have still some kind of sensation or signal coming from the lower neuron. So you still have you have a spastic DTR instead of a lost one. You lost the top conduction chain, but the bottom conduction chain is still kind of hanging on. So you do have some stimulation of it still. You get it? Because the lower one is functioning, even though the top one's not sending the signal per se. So, and that pretty much corresponds with all the difference between upper motor and lower motor neuron. Let's write that down. So lower motor neuron. Hyporeflexia. And upper, it's just the opposite, you know. So whatever I put here is the opposite here. Hyporeflexia. What else would you think? Loss or decreased DTRs. What else? Muscle atrophy. Would it be worse in lower motor neuron or upper? Much worse. You have severe atrophy. You get some atrophy. You get actually some atrophy in upper motor, but it's actually mild only. Mild at worst to moderate. But never the kind of atrophy in the muscle wasting you get with lower motor neuron disease. Does you guys kind of get it? Right. Hypo, this is hyper. It could be, yes. No, it could be. Absolutely. You could present as a lower neuron sign first. Absolutely. Hyperreflexia.
Dr. Ecker?
Yes. You lost.
What are the two titles that you have up there? I can't see that.
Which one? This one?
I can't tell either.
This one is this is lower motor neuron, and this is upper motor neuron.
Okay.
Spasticity. Loss of tone. And that's it. Break, 5 minutes. Somebody get me a drink. Yes. No. No. No, no. Anywhere there's demyelin, absolutely not. It can start anywhere. In fact, the first symptom, honestly, in 70% of cases, and this is absolute, is fatigue. That is the number one first severe symptom. And then people start noticing muscle weakness, but they don't think, let's say a guy's walking 5 miles. A year later, he's only walking 2. But he doesn't report this to his doctor, God forbid. But seriously, I have a patient, you guys, mentioned nothing to me till it was too late. Yeah, it's horrible. And it affects the respiratory muscles too, right? Diaphragm. Horrible. Oh. Well, you're gonna die anyways, quite frankly. And I mean, there's only 2 cases I know of people who lived, and one is Stephen Hawking. I know there's an athlete, I can't remember his name. Who the hell knows? It's inexplicable. He was supposed to die, obviously, a long time ago. Oh Lord. No format. No, just I speak critical thinking, literally. I don't know how to clarify critical thinking, but like, right. And if it's why, and you think it's that, why you think it's that? What other differential could it be? And if it's not differential, how did you rule that out? Honestly, I know you're supposed to put HPI and all that stuff. I don't really care about seeing that. And I know it's vague what I said. I know, but okay, how can I give you an example? Not really. No, it can't be. No. You're talking to somebody who pretty much knows everything. It can't be. Trust me. It can't be a lot of things. Believe me. And again, if you put the things you could be most commonly, I don't expect you to put 10 different things. 4 things at the most. Don't go overboard. But I think at least 4 sensible things could be, because there are other things it could be, but they're much less likely. So basically, on the scale of like, right, are the more common ones. If you want the 4 is good. And honestly, if you're not even close, again, I see you're critical. If you're thinking, again, the answer to me, if you get it right or wrong, is not even relevant to me. I want you guys just thinking about the actual, thinking deeply about the diagnosis and trying to put your piece together, not going to textbook and rewording something. What happened? Oh, I haven't looked at it. I don't know. I'm way behind. You're making more work for me. I don't make more work for me. And if any of you guys have questions on the case study, and like if you guys are really that lost, email me. No, but if you think it could be 10 different things, I'll explain to you why it's not 10 different things. I mean, that's fine. I know, it's no problem. The more I have time to call, so I can, because writing is too much. No, let me see.
What you think it is,
Right.
and then we are doing all of this
Right.
because we have the differentials that we want to rule out.
Well, you're right.
And we put like what we're thinking,
Right.
why we're doing that, and then we just listed the differentials. We weren't
But
sure.
why, and I know why, but to rule out lymphocytosis and check for protein. So what does that mean? For what? What are you gonna ruling out? Viral processes, right?
Yes,
Like a viral,
yeah,
right?
because we're
A viral
taking,
what?
infection and inflammation
Right,
process.
right.
Like, have meningitis.
A viral encephalitis, right?
Uh-huh.
Exactly. So you put that there.
Okay.
To rule out. Right?
We had it, we took it out.
No, that's what I
Okay,
want. This
and
is
then-
what I want to see, basically.
And
You
then
know,
the other thing
and
was
why the Romberg's test?
because any gate disturbances, any gate problems.
That would lead you to believe that there's a neuromuscular issue.
Yes,
Or a
uh-huh.
cerebellar issue.
Right,
Right.
that's why we had the attacks.
Put that there.
cerebellar attacks, yes.
Okay.
We put it on the
Right.
differential diagnosis.
I'm glad you brought that up. Actually, I didn't bring that up. Triad.
And then we didn't know about the medications if you wanted us, because we're saying, well, refer to the neurologist.
Right.
We're thinking they're gonna do all the other stuff, but like, to treat the fatigue, or do we treat just the neuropathy and the fatigue? You know?
No, you can put.
We can say the fatigue as well, because that's the main problem, but the him problem.
Right.
Fatigue.
I care more about you working the diagnosis up than you putting the treatment.
Okay. So
Honestly,
then just leave it like that, and
yeah,
then
I don't
just
care about
put
the treatment. But when you say something like especially exactly this, 6 months would rule out lymphocytosis and check for protein to rule out. Okay. You're basically looking. If you're checking for that, what are you looking for? You're looking for some kind of encephalitic or meningitic viral syndrome.
So any viral syndrome.
Right.
Like
Right.
Okay.
Right. Because you're going to have the lymphocytosis and you're going to have the elevated protein.
Okay.
Right.
Okay.
Right. Perfect. That's good. Huh? He died. He's dead. Yeah. She hasn't called me in a while. I don't know. Yeah. Yeah. But he respiratory. Like pretty much all ALS people. Listen, this first case study I'm going to grade because you guys are new to how I want things. I'm going to be very mild with grading, very, very open. So it's not a big deal. I know you guys can put, preventive care. I know you can put diet, exercise. I know you can. Everyone can write that. Huh? No. Well, you need honestly. If it's an exacerbation and severe, they should get IV steroids. Yeah. Yeah, they should. If it's yes, absolutely. That's the mainstay treatment, and they're not going to do that at home. So. But yeah, if somebody comes in with diagnosis who has MS and they come in to your office, and unfortunately that will happen, which is these people should know, most of them should be educated that when they have exacerbation, you need to go right to the emergency because they need intravenous steroids, or you will have that happen. Unfortunately, that's going to happen. Okay. So ALS, we know causes motor neuron disease. Is everyone back? Oh no, not everybody's back. Wait. Do you guys understand the upper motor neuron, the difference? So if you have a lesion in the brain affect the upper motor neuron, you're going to get these kind of symptoms. You're not going to get those at all. So with MS, you're more likely to see an upper motor neuron lesion. 9% of the time, it is going to be upper motor neuron with MS. You're going to see this spasticity with the walking. Have anyone seen a patient with MS? It's a lot more spastic and just, like their leg will just kick out. I mean, I've seen so many, so it's and really the sensory portion is the big. And you know, somebody brought up, but they have something called Charcot's triad when it affects because MS can affect obviously the medulla. Because it has nuclei in there also, it has motor nuclei. And there's something called Charcot's triad. I mentioned that because some people do present with that. Not very common, but it's tremors, nystagmus, and dysarthria, which is, so they basically are, it's not super common presentation, but it's one of the presentations. I'm not expecting you guys to know that, but. Yes. Right. It depends what's being affected, the lower motor or so. Yeah, absolutely. Oh, in most cases, you're going to have both. Yes, both. So it can be affecting one portion of the upper motor neuron somewhere and the lower neuron somewhere. It can be all upper motor neuron in one limb, right? Yeah. Yep. You can have it in both limbs. You can have it literally because it affects both upper and lower. You can have basically a coalescence of all these different symptoms. You'll never see a patient honest with ALS that only has one. It's not going to happen. I've never seen it. They end up getting just a multitude of different things affect them at once. Yes, bulbar onset. We'll talk about that. Bulbar is the nuclei that control the motor neurons in the medulla. The medulla used to be called the bulb. That's why it's called bulbar. Uh-oh. So cute. Okay. So now we have, okay, hopefully everybody's back. Is everybody back? How can I tell? Okay, ALS. So it can affect upper and motor neurons. Remember, MS is motor and sensory. So if you do an EMG, electromyogram, and it shows that both you have delay in sensory and motor conduction, MS, and it just delay in motor conduction. Right, exactly. Amyotrophic lateral sclerosis. Lateral refers to the lateral corticospinal tract.
The camera is blurry and not on board.
You see me? No, I can't see my picture. What am I?
There it is.
Yeah, okay. Yeah. Is that better?
Yes.
Okay, good. Okay. So I don't know if you guys were all on, but an EMG with ALS would show motor symptoms only. So decrease in action potentials for the motor, for the muscles, for skeletal muscles specifically, right? And MS is going to show both sensory and motor disturbance, obviously. Okay. So it's important. Motor and sensory, upper motor, lower motor neuron. ALS. But amyotrophic lateral sclerosis. Okay. One of the first symptoms of ALS, fatigue. And first symptoms really fatigue and weakness. Example, somebody gets a lot tired, who used to walk again 5 miles, after they walk 2 miles they're exhausted. And they don't really notice anything different. Or they do biceps curls at 20 pounds. They're doing 20 reps one time, 6 months later they're doing 8 reps. Honestly, that's a big part of the presentation. Most cases, it's limb involvement, weakness in the limbs, legs and arms. So 70 to 80%, let's say, limb involvement. Okay? That's by far the most common presentation you'll see. Again, I don't care about you guys knowing these percent. Just know that most people are going to present with limb involvement. The majority present with limb involvement. I've actually never had someone present with bulbar onset ever, but 20 to 30% for the textbook is bulbar onset. The bulb refers to the medulla. It used to be called back in the dark ages of medicine. The medulla is known as the bulb. So what nuclei are on the medulla? Seven to 12. Yes. Cranial nerve nuclei? Cranial nerve. Don't those some of those have a motor portion? Cranial nerve 7, motor portion, all your facial movements. Hypoglossal, swallowing, right? So the bulbar onset is going to affect these cranial nerves, medulla, bulb, bulbar, medulla, cranial nerves, 7 through 12. Think about what each of these cranial nerves do, right? So what's one of the biggest? Speech. So you're going to have dysarthria, right? Hypernasality. All right, talk like S. Yeah. I get it. Dysarthria, hypernasality, issues with swallowing, which is a big one with MS. With ALS, pardon me. So bulbar onset, you're going to have problems with the bulbar nuclei. I think that would be actually more, if somebody present like that, I think it'd be a more difficult diagnosis because, I mean, God, brainstem lesions, brainstem stroke, I think this would make it much more difficult for diagnosis personally. But that would be a huge differential. Even there could be so many things that could affect the medulla only. So bulbar onset versus limb involvement. But again, really, limb involvement is what you guys really need to focus on. Are there any genetic forms of ALS? So you have ALS. You have two forms of ALS, really. You have familial form, which is, yes, a lot easier to figure out because you have family members that have it. And you have a sporadic, which is by far the most common.
The gene mutation, isn't it?
Right. The two biggest genes. Right. Exactly. So let's say you suspect the familial form that, for some reason, because you see patients who have no concept of their medical history, they don't know, they have no clue. That happens all the time. There's the two biggest gene mutations to test for is C9ORF72 mutation and SOD1. Oxide dismutase 1. So those are the two biggest gene mutations. This accounts for about 70% of the familial forms of ALS. So you actually, if you suspect the familial form of ALS, you can test for those, and it's 100% specific. Unfortunately, the familial is by far not the most common. It's very uncommon compared to the sporadic one. But the nice thing is, although if you do even the sporadic one, and because about 10% of people with sporadic ALS also have this gene mutation, and about 1 to 4% have this gene mutation. Again, I don't expect you guys to know these percentages, but just know that you can test these gene mutations to, if you're not sure of the diagnosis, which ALS really is more of a clinical diagnosis anyways, but if you would try to, this is a help, EMG, are you doing an MRI in people that you suspect of ALS? Are you doing an MRI in people you suspect of ALS? Are you guys going to do an MRI? Then we're going to do an MRI. You have to do an MRI, absolutely. You're going to do an MRI. It's probably not going to show anything, but you need to do one. Because couldn't ALS initially present, couldn't it be MS sometimes with presentation? Sure, absolutely could be. So limb involvement, number one, you have familial forms, and you have genes you can test for. I don't speak things I want to cover. Okay, treatment. life expectancy ALS is very short. You have people live as long as 3 months. You have people live 2 years. You have people like Stephen Hawking who live indefinitely. But in general, it's the prognosis is is very poor. There's only actually one treatment to extend life expectancy. There's only one treatment. It's called riluzole, and it only extends treatment life expectancy for 3 months, 3 meses. That's it. And actually in some 3 months, whatever. And some neurologists say it's not even that long. So 3 months, riluzole. It actually reduces glutamate. Glutamate is the first neurotransmitter involved coming from the central nervous system involved in movement. I'm not going to go into all the different neurotransmitters, but it's the main one in the central nervous system in the motor cortex. So it suppresses this neurotransmitter. They're saying by suppressing this, it's reducing some of the stress being put on the corticospinal tract. So riluzole is the only treatment, and suppresses glutamate. There's a new FDA-approved medication that just got approved. It's been approved in Europe for a while. It's called Radicava. Just was approved for here, and this does not extend life at all. This improves function. Has nothing to do with life expectancy. Improves function, functional. I've never seen it used, obviously. Riluzole, honestly, you have people, the majority of people take it, there's really no clinical determination that it improves anything. So unfortunately, there's no treatment for ALS, in other words. It's supportive care, right? Ventilation, feeding tube. That's what you see with ALS. So as it progresses, it will affect the bulbar nuclei eventually. So you won't swallow, you won't chew, so you get a feeding tube. You won't breathe, so you get ventilation. So treatment is honestly palliative. Yes, supportive is a better word. Initially, non-invasive ventilation. What is that? What? What's non-invasive ventilation? Right, CPAP, BiPAP. Mucolytics, because if you lose control of the muscles of your throat, what happens to your secretions? This part of the mouth, literally. Right, you can't control your secretions. So literally the spit that's produced in your product glands will just accumulate in your mouth. And the mucus in your throat. So you use mucolytics, anticholinergics to reduce secretions. Antidepressants. For pain, you use NSAIDs. You give more of the hell they want, in my opinion. Marijuana, that's what you give them.